Welcome to our CME and SDMS CME accredited ultrasound webinar, State of the Art CEUS of the Kidney, Liver, and Pediatrics. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forms, the CME provider for this program. Northwest Imaging Forms is accredited as a CME provider by the ACCME. Northwest Imaging Forms designates the CME activity for 2 Category 1 credits towards the Physician's Recognition Award of the American Medical Association. Sonographer SDMS CME is also provided for those wishing to receive up to 1.5 hours of credit. The planner of the CME activity has nothing to disclose. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to their respective presentations. They will respond to questions in the discussionary period towards the end of our time allotted. It is now my privilege to introduce Stephanie Wilson, MD, FRC PC, Clinical Professor of Radiology and Gastroenterology, University of Calgary, Calgary, Canada. Dr. Wilson.
Hello, everyone. Welcome to our webinar. I speak to you as the co-president of the International Contrast Ultrasound Society. I'm also on the Educational Planning Committee, and this meeting, state-of-the-art CEUS of the Kidney, Liver, and Pediatrics, is a very special session for us. And so we're very happy to have everyone here today, as this is a repeat of this topic, allowing us to keep you up to the state of the art for these very important parts of CEUS. And so, as everyone knows, liver, of course, has been the major approval indication for microbubble use in the world. And when the FDA in the United States gave their approval in April of 2016, they also very wisely included pediatrics. And so this is, as I said, a very special presentation to us. And now I'd like to say just a few words about ICUS. So ICUS is the only global professional society that is solely focused on contrast-enhanced ultrasound. So we advocate for the use of CEUS, we promote the use of CEUS, and of course, one of our major activities is in the presentation of webinars and educational activities, such as that which you are listening to today. I'd like to point out to you that we would like all of you to join ICUS, and you can see there right on the top line that you can see the website there, and membership in ICUS is free. It includes free webinars and also free CME credits for live and for archived programs. It includes a free weekly CEUS news monitor, and free point-of-care apps are coming soon. And so we have a very comprehensive website, including case of the day challenges, sonographer resources, bubble blogs, a reimbursement guide, and practice guidelines. And so we'd like to welcome all of you to be part of our global ICUS community. We have members today in over 60 countries, and it's a global collaboration among physicians, sonographers, nurses, scientists, industry, and our patients. And it bridges many clinical aspects of medicine, including radiology, cardiology, hepatology, vascular imaging, and GI medicine, and actually many more. And we welcome you to tweet ICUS, and we'll now go back and look at our webinar for today. Welcome to all of you.
Thank you so much, Dr. Wilson. It is now my pleasure to introduce our first speaker, Richard G. Barr, MD, PhD, FACR, FSRU, FAIUM, Professor of Radiology, Northeast Ohio Medical University. Dr. Barr.
Hi, I'm Richard Barr. I'm a professor of radiology at Northeastern Ohio Medical University. And today I'd like to talk to you about mass characterization relative to the CT and MR Bosniak classification system regarding ultrasound contrast studies of the kidney. I have the following conflicts of interest. So indeterminate renal masses are a common clinical problem with an estimated more than half of patients over the age of 50 having at least one renal mass. Renal masses are often found incidentally during an imaging examination, and other than inflammatory masses or vascular abnormalities and pseudotumors, most solid, contrast-enhancing renal masses are malignant. Complicated cystic lesions with enhancing components, excluding the actual cyst wall, are malignant. These complicated cystic lesions are classified using the Bosniak classification system, originally described for CT and often applied to other modalities. The classification is based on the probability of malignancy, and a recent update to the Bosniak classification for CT and MR was designed to help decrease false positive results. With subtle septations or nodular masses, determining enhancement with CT or magnetic resonance imaging may be difficult because of patient size, patient motion, lesion size, technique used, image noise, partial volume imaging, or the inability to use contrast agents and the development of pseudo-enhancement. There are several advantages to ultrasound contrast agents. There's no radiation used in the imaging. The ultrasound contrast agent does not have renal toxicity and can be used in renally impaired patients and in those with renal obstruction. Thin slice thickness improves spatial resolution, improving characterization of septations and nodularity, and determination of enhancement without the volume averaging seen in CT and MRI. Real-time imaging detects enhancement that can be missed on the snapshot images of CT and MRI, and CEUS subtraction techniques remove the background soft tissue with production of a contrast-only imaging, allowed for visualization of enhancement in small structures such as septations or small mural nodules. Also, it should be noted that CT should not be the first-line imaging modality to assess cystic lesions with most probable benign character due to its relative radiation exposure, as pointed out in a recent white paper by the FDA. Let's talk about a few of the features of ultrasound contrast. Slice thickness. Ultrasound is a substantially thinner slice thickness, less than 1 millimeter than CT or MR, usually 2.5 millimeters. The Bosniak classification used septation thickness and enhancement to provide a Bosniak score. Therefore, the slice thickness of septations may be different than CT or MR. However, what is probably more important is that the characterization of septations in CEUS not only includes thickness and enhancement but nodularity. A thin septation with enhancing small 1 to 2 millimeter nodules has been shown to be highly diagnostic of malignancy, whereas a thin septation with a linear flow of bubbles is a benign finding. These small nodules are usually not seen on enhanced CT or enhanced MRI due to volume averaging. And here is an example. The image on the left is an ultrasound contrast image that shows a nodule that is enhancing within this cystic lesion. The images on the right show a CT scan without and with, and you can see that we have enhancement from 57 to 71, less than the 20 enhancement units to suggest that this is a malignancy. And if we look at the lesion itself, it's very hard to determine that there is a nodule within this cystic lesion. And that was a cystic renal cell carcinoma. This MR, the lesion appears to enhance and have washout. And on ultrasound contrast, the image on the right, there's absolutely no enhancement in the lesion. And again, this was felt due to volume averaging and patient motion, which gave the appearance of enhancement with washout. In terms of septation, it is not uncommon to see individual bubbles traversing a thin septation. This is a benign finding and should be classified as enhancement or not. We don't know. A continuous stream of bubbles without nodularity and having a thickness of 1 bubble diameter can also be seen, and this has been shown also to be a benign finding in long-term follow-up. A thin, less than 2 millimeter septation with nodularity is a malignant sign of ultrasound contrast. Using the recommendations for CT or MR, this would be classified as a Bosniak 2. Therefore, a Bosniak classification for CEUS needs to include these small nodularities in thin septations that we can see enhancing on CEUS. And here's an example again of improved visualization of septations. Here you can see on the middle image septation on ultrasound without contrast, and on the image on the right, absolutely no enhancement of the cyst. And if we look at the CT scan, It has a -3 enhancement, but it does have a calcification in it, suggesting this is a Bosniak 2 cyst, and because of the calcification, may be followed up to make sure it's stable. And again, here we can see improved visualization of septations. In this case, on the left, we have MR without and with contrast. And I think you can agree that the septations are enhancing. They're less than 2 millimeters, so this would be a Bosniak 2 cyst based on the new Bosniak classification. However, when we look at CEUS, we can see that there are several enhancing nodules attached to these septations. And this was a cystic renal cell carcinoma. Again, the advantage of seeing these small nodules enhancing is a diagnostic indication of this being a renal cell carcinoma, and these are often not seen on CT or MR secondary to volume averaging. And here's a case showing this on MRI, again with enhanced MR in the left. You can see that there's a mass, questionable enhancement, and we see some thin septations. And again, when we look at the CEUS, we can see that the mass, if you will, shows no enhancement and was a hematoma at surgery. And if you look at the septations, we see several nodule, or I call them little berries, hanging off the septations in this cystic renal cell carcinoma. Ultrasound contrast also has significantly improved background suppression compared to CT and MR. We really have a contrast-only image on CEUS. Thick enhancing septations will most likely not be much different on CEUS and CT, although with the excellent background suppression of CEUS, small amounts of enhancement may be identified on CEUS that may not be as evident on CT or MR with contrast. Many complicated cysts are not purely simple and contain material that leads to changes on CT and MR non-contrast images, and there may be difficulty in assessing if there is enhancement or not. Here is a couple cases. Image on the left shows a cyst, Hounsfield unit 66. On the right, another case, CT with contrast, 2 cysts, very similar in appearance. Hounsfield's readings of 103 and 78. And if we look at the ultrasound contrast, the image on the left is a papillary cancer showing mild enhancement after contrast enhancement on ultrasound contrast, and the 2 cysts on the left show no enhancement and are benign cysts. We also have very high temporal frame rate on CEUS, and this high temporal frame rate with cine loop capture allows for visualization of moving bubbles, increasing the confidence of enhancement or not volume averaging or artifacts. Uniform high or low Hounsfield units or MR intensities are included in the Bosniak 2019 classification. Using these values of the degree of enhancement after contrast enhancement, a lesion can be classified as benign. However, particularly in capillary renal cell carcinoma, the enhancement is usually seen mostly in the early arterial phase and then decreases, and it is not uncommon for these lesions to appear as benign cystic lesions on CT or MRI. These lesions are clearly identified as malignant on CEUS as the early arterial enhancement is clearly seen. So here's an example again showing on the left a CT without and with contrast, having a Hounsfield unit of 11 pre-contrast and 27 after contrast, so less than the 20% threshold to call this malignant. However, if we look at the ultrasound with contrast on the right, the mass is clearly enhancing, although it is enhancing less than the renal cortex, and this is a papillary renal cell carcinoma. And here are some images from the cine loop of this case. And what you can see is that at 10 seconds after injection, we start to see bubbles within the mass. At 20 seconds, we kind of have peak enhancement of the mass, and then after that, we get washout of the mass, and by 60 seconds, there's very little enhancement left within the mass. So obviously, if we're doing snapshots in CT or MR, and we don't hit those appropriate time frames here, 20 or maybe 30 seconds after the arrival of contrast, we're going to miss this finding, and it would be classified as benign and not as a papillary renal cell carcinoma. And again, here's another case. This is now almost 20 years old, and it is a case that was sent in for a renal stone protocol on CT, and I have the without, the portal venous in the delayed phase, if you will. And what you can see is that there are cystic lesions involving the upper pole of both kidneys. They look identical on the right and left in every phase on CT. However, when we look at ultrasound contrast, the lesion on the right shows an enhancement and was a papillary renal cell carcinoma at surgery, whereas the lesion on the left shows no enhancement and it was a benign simple cyst. Other factors, many lesions, a contrast study is required for accurate characterization using the Bosniak classification. So in patients that cannot receive an ultrasound or, a CT or MR with contrast for various reasons, CEUS would be the method of choice in evaluating these lesions. Many renal masses are identified on CT or MR, not using a dedicated renal mass protocol. And in these cases, CEUS may be used to decrease radiation dose and the expense of the examination. So in this case, which was done only without a unit of 36 for the Hounsfield reading of this renal mass, which is not being able to be assigned a Bosniak score without doing an additional study. And here, doing an ultrasound contrast confirms that this is a non-enhancing complicated cyst. Another important feature is, I think, when we see these small nodules in these cystic renal cell carcinomas, it's important if we're going to do a biopsy that we biopsy the enhancing lesion. And since these are not seen on CT or MR, it's really not appropriate to be using CT or MR to guide the biopsy, as what we should do is use CEUS and guide the biopsy to include the enhancing portion of the lesion. If we look at a study that we published in Radiology in 2014, we compared, again, this is using the old Bosniak classification. If you look at the number of lesions and if they were CEUS positive or negative, what you can see here is that for Bosniak 2 lesions, we do quite well. But in Bosniak 3 lesions, approximately 1/3 of these lesions actually are enhancing and were cancers, and 2/3 did not show enhancement and were benign on 5-year follow-up. And therefore, if we use the CT and MR classification suggesting that these may need additional follow-up, biopsy, or surgery, then we are sending a lot of people for unnecessary tests. Even if we look at Bosniak 4s, if they are positive on CEUS, the vast majority of these turn out to be cancers, although we do have enhancing masses such as oncocytomas that would be false positives in this situation. But we do see actually about 1/3 of the cases actually showed no enhancement and were benign and could therefore have not been sent to surgery or biopsy. And again, when we're looking at the probability of malignancy, according to what we see in our practice over 20 years, no enhancement, including septations of any thickness. The follow-up over a 10-year period is 0% chance of malignancy. Thin, less than 2 millimeter septation with occasional single bubbles. Again, no chance of malignancy in our studies. Enhancing septations with any thickness and nodularity. 96% of these turned out to be malignancy. And we do have some that have thicker septations, thicker than 2 millimeters, that show enhancement but no nodularity. And I don't think we have enough of these cases yet to know exactly how many of these are going to be malignant. So we call them indeterminate and recommend a 6-month follow-up CEUS. So again, in a non-enhancing renal mass, what is the probability of it becoming malignant? We just did a study that we are submitting for publication that included 2 Bosniak 1 cysts, 402 Bosniak 2 cysts, 99 Bosniak 3 cysts, and 9 Bosniak 4 cysts. And the probability of malignant change, again, these are all masses that did not have any enhancement on CEUS. In 5 years was 0%, and at 10 years, again, was 0%. So commonly encountered indeterminate renal masses that lead to follow-up biopsy or surgery. If there's no enhancement on CEUS, the benignity of the mass is confirmed, limiting the need for further evaluation. And again, here is the results. And again, the number of lesions and the years we followed up. And again, you can see that we did have a few lesions that resolved over time, a few lesions that got larger, and we actually had one patient that developed a renal cell carcinoma, but not in the mass that showed no enhancement on ultrasound contrast, but it was in a different location. And again, if we look at the Bosniak score, you can see that the majority of the lesions that we call benign were Bosniak 2s, but there were a significant number of Bosniak 3s and a few number of Bosniak 4s that with no enhancement that we could have said were benign and didn't need any additional follow-up. So to conclude, both overdiagnosis and underdiagnosis of cystic renal masses can be made with CT or MRI. A dedicated renal mass CT is often not the examination where the lesion is identified. An accurate Bosniak score may not be able to be assigned, and repeating a dedicated renal mass CT to characterize a lesion adds radiation, and the FDA recommends against this. Narrow slice thickness of CEUS allows for visualization of small enhancing nodules and cystic renal cell carcinomas, often not identified on CT and MRI. Volume averaging leads to false positive and false negative results on CT and MRI. And real-time imaging in CEUS allows for improved assessment of renal mass enhancement, mostly in renal papillary cell carcinomas, where contrast timing is critical to make that diagnosis. There are situations where a Bosniak score cannot be given based on CT or MRI findings, and CEUS is the best method of choice to use in these cases. If a lesion is to be biopsied, it is critical to biopsy the enhancing component, which are often not identified on CT or MRI. Assessment of enhancement of some septations on CEUS is difficult if the background subtraction of an echogenic septation is limited. Experience is needed to assess these properly. And the Bosniak classification is based on the probability of malignancy. With CEUS, almost all lesions can be classified as benign or malignant with high confidence, and therefore trying to use the CT and Bosniak classification will limit the advantages of CEUS. Studies are needed to determine the probability of malignancy of CEUS findings, as well as a new Bosniak classification, as we have for CT and MR for ultrasound with contrast. Thank you, and I hope this has been informative, and I'm looking forward to your questions at the end of this talk.
Thank you so much, Dr. Barr. And go ahead and continue to use the Q&A function at the bottom, and we'll take all questions at the end of our respective presentations. We'd now like to continue with Dr. Wilson.
Thank you very much. It's my great pleasure today to talk about liver ultrasound, why CEUS. And I've divided this into a special component of why CEUS, and we'll look at problem solving with CEUS in the liver. So my disclosures are not substantial and include equipment support from Philips, Siemens, and Samsung. So what we'll do today is, using brief case presentations, predominantly in oncology patients, and virtually all of them at risk for HCC, will show the most significant benefits of contrast-enhanced ultrasound. So these include its dynamic real-time scanning capability, the use of a purely intravascular contrast agent, a focused nodule-based exam, using the subtraction technique that Dr. Barr nicely described, which allows us to have microbubble-only images. And so when we're doing these CEUS exams, when we're looking at the CEUS images, all that we're looking at is related to the microbubbles and not the background. In addition, we have very thin slice thickness, and this avoids the problem that CT and MR are encumbered with, and that is volume averaging. And so what does this allow us to do? It allows us to diagnose liver tumors, and CEUS allows us to predict malignancy. It resolves indeterminate MRI, and it resolves pseudolesions that occur from shunting in the liver. So let's start off looking at two similar at-risk patients who we'll call 1 and 2. So both of these patients are 55 years old, and they have risk for HCC in that they are HBV carrier status patients. And they each have a lesion found on a surveillance ultrasound. So let's look at these lesions that are found. So both patients have a very similar superficial mass. The mass in patient 1 is hypoechoic with a faint echogenic rim, and the mass in patient 2 on the right is a hypoechoic lesion. So when we look at them on CT and MR scan, this is obviously MR scan, and this is the recommended technique to be used for characterization of nodules found on surveillance ultrasound. So you can see that we show a focus of arterial phase hyperenhancement that corresponds precisely with the nodules that are shown on the surveillance ultrasound. On the later images, which are not shown, there was no washout of these lesions. Therefore, although we confirm that they're real lesions with APHE, the result is indeterminate. Consequently, the patients come for contrast-enhanced ultrasound. So on grayscale, we see the nodule, and when we look at the wash-in CEUS files, you can see that the patient on the left has got peripheral nodular enhancement, centripetal progression, very rapidly making a completely enhanced nodule. And that's in comparison to the enhancement on the nodule on the right, where we can see after we localize the mass precisely right there, that we have globular APHE. So they have very different patterns in the arterial phase. So now if we go on to look at the later imaging, let's look at patient 1 first. So we can see the still image at the top showing the peripheral puddles of enhancement. And then in the portovenous and late phase, we really cannot identify the nodule again. It has disappeared. So obviously it has sustained enhancement. And so when we interpret that, we interpret it as an insignificant flash-filling hemangioma. And when we look at patient number 2, we can see the globular arterial phase hyperenhancement on the top line in the arterial phase. And then on a 2-minute still frame, we see that there is late and weak washout. The washout is late because it occurred at later than 1 minute, and it's weak because it still has multiple bubbles left within the washout zone, but the washout zone is less enhanced than the adjacent liver. So what is that mass with late and weak washout following globular arterial phase hyperenhancement? This is a classic HCC, and according to LIRADS, this is an LR5 lesion. And as long as we follow the absolute criteria shown here, this lesion can be treated without biopsy. So what are the CEUS advantages we see in these 2 very simple cases? Well, first of all, the dynamic real-time ultrasound shows the rapidly changing arterial phase enhancement patterns of both tumors, and it allowed us to show the peripheral puddles and the centripetal progression of the hemangioma, making this very suspicious on the arterial phase alone. So ideal for the diagnosis of benign tumors. In addition, it resolved indeterminate MRI. It shows the enhancement in the portovenous phase with accuracy. So the sustained enhancement suggesting a benign tumor and the washout suggesting a malignant tumor, here an HCC. So let's look at 2 other similar patients at risk for HCC. Both are elderly women, the patient on the left with HBV cirrhosis, the patient on the right with HCV cirrhosis. And you can see that the arrow in both patients is pointing at a well-defined mass with a hypoechoic rim in the right lobe of the liver. So certainly on the grayscale, these lesions are indeterminate as to their nature. So when we look at the arterial phase wash-in on these nodules, we can see immediately that both masses are hyperenhanced. And so arterial phase hyperenhancement, making a slightly heterogeneous image on the grayscale or on the single frame image. So let's go on now and look at these in the portovenous phase. So let's talk about patient number 1 first. So you can see that on both patients, I've included a 1-minute film and a 3-minute film. So what is the significance of the 1-minute film? Well, the 1 minute represents the threshold time. If washout occurs at less than 1 minute, we think of non-hepatocellular malignancy, whereas if washout begins At later than 1 minute, we think of hepatocellular carcinoma. So patient number 1 on the left, at 1 minute, you can see that the nodule is still enhanced. However, if we look at the 3-minute image, we can see that there is late and weak washout. So late because it occurred after 1 minute, and weak because it still has bubbles within the region of the tumor. So what does that suggest to us? This is a pathology-confirmed HCC or LR5. Now let's look at patient number 2. Patient number 2 on the 1-minute film clearly has got weak washout. However, with time at 2 and 3 minutes, it becomes marked. So that rapid washout is of critical importance. Washout prior to 1 minute, and that is an LRM, and this is a biopsy-confirmed cholangiocarcinoma. So LR5 is definitely HCC with high specificity, and LRM is probably or definitely malignant, but not HCC specific. So CEUS easily shows the characteristic features to suggest either hepatocellular or non-hepatocellular malignancy. So here in the portal venous phase, based on different washout parameters, we can distinguish LR5 from LRM and hence proceed with treatment of these patients very, very much more optimally. So let's look at another patient with NASH cirrhosis, and this patient has an MR scan as his beginning scan. So on the T1 image on the left, we can see the arrow is pointing at a tiny T1 dark nodule. And then when we look at the 3 images in sequence across the top, we can see that in the arterial phase, the portal venous phase, and the late phase, the nodule is hyper-enhancing. So this tiny nodule, which measures 8 millimeters, do you believe that it would be diagnosed on this MRI? Probably not. Most likely this would be recommended to have 3-month follow-up. And this could be considered as potentially an LR4, a highly suspicious lesion for HCC that doesn't have washout yet, or it could be considered as a possible LRM, but it is indeterminate. So in my center, this patient is referred for contrast-enhanced ultrasound. So when we see the contrast-enhanced ultrasound, first we look at the grayscale and we see this small nodule and we measure it at 1 centimeter. So when we look at the arterial phase wash-in in the center, we can see that this tiny nodule has actually got, at the very peak of the arterial phase, it has an arterial phase hyperenhancement with a rim pattern, and a still image is taken on the right-hand image. So let's go on now to the portal venous phase. So when we look at our small nodule, we can see that at the peak of the arterial phase, we had APHE rim pattern, and then at 30 seconds, we can see that the nodule is darker and the rim is disappearing. By 1 minute, the rim is completely gone. And when the only thing that hyperenhanced is the rim, when the rim is gone, that is called washout. This is less than 1 minute. So this is rapid and marked washout. And so what do we think of this? Well, CEUS led to the conclusion that biopsy was warranted to exclude non-hepatocellular malignancy, and we biopsied this tiny lesion, and this is a proven and treated cholangiocarcinoma. So what are the advantages that we show here? Well, we see that CEUS is very good at identification of sub-centimeter nodules. CEUS is also very good at characterizing sub-centimeter nodules, and it's ideal for the diagnosis of tiny HCC and ICC. And in this case, it was the rapid washout at less than 1 minute that prompted us to suggest biopsy and allowed us to obtain early diagnosis and treatment. So let's look at another patient with NAFLD. So this was a patient who on regular ultrasound surveillance has this tiny solitary lesion in the liver. So as per the AASLD guidelines, a contrast examination is required. And what they recommend today is that we do MR scan. So MR scan of this tiny nodule, similar to the other tiny nodule I showed you, shows APHE with no washout. And this was called an LR3 nodule, an indeterminate nodule. So a patient was sent for a contrast enhanced ultrasound. So when the patient comes for ultrasound, we can see that with the wash-in of the contrast, in spite of the small size of this nodule, we can see it very easily with a globular pattern of APHE. And so the teaching point here is that CEUS shows avid arterial phase hyperenhancement, but this can be seen in both benign and malignant masses. It's not a specific enhancement pattern. And so we have to go on to look at the later images. So at 30 seconds after the hyperenhancement, which was at its peak at 17 seconds, we can see that at 30 seconds, the lesion shows washout. At 1 minute, again, definitely washed out and quite marked by 2 minutes. So rapid washout before 1 minute, it suggests non-hepatocellular malignancy, or it suggests LRM. We have to biopsy all of these lesions. And again, this is a tiny lesion, a confirmed cholangiocarcinoma on CEUS. So what about occult tumors? Well, if you look at the literature and talk to people who do liver imaging, everybody believes that ultrasounds may see occult tumors or may not see occult tumors. However, we know that there are occult tumors on ultrasound, which we acknowledge, but we know that they can also be present on MRI. And I'd like to show you a beautiful example. So this is a 69-year-old male who has HCV cirrhosis. And this surveillance scan was done in my department. So here we can see a long axis and an axial view of the tip of the right lobe of the liver. So this beautiful scan shows a hypoechoic mass in the liver measuring about 1 centimeter. And so we do immediate characterization of this mass, and you can see our still image showing the arterial phase hypervascularity, and then the late and weak washout, which didn't occur until 2.5 minutes. So these are the characteristic features of classic hepatocellular carcinoma. This is LR5. So the patient then went on to have MRI for staging prior to treatment. So when the MR scan was performed with Gatovist, the report came back that there was no nodule on MR scan and that there was no arterial phase hyperenhancement. And so the patient, therefore, according to AASLD guidelines, again, went to CT, the alternate modality, and they also show no mass and no hypervascularity. So a half year later, this patient came back to our multidisciplinary discussion rounds. And when we discussed this patient, we suggested to do a Primavist or a liver-specific contrast agent. And on the MR Primavist scan, you can see that in the vascular phase, again, there's no nodule and there's no hyperenhancement. However, when we look at the delayed imaging, which we get with these specific contrast agents, there we can see the nodule in the precise location that we saw it on ultrasound greater than 6 months earlier. And on the coronal imaging, again, in the vascular phase, the coronal image on MR does not show the tumor. However, on the delayed imaging, we can see the arrow pointing to the small tumor, and this is a biopsy-proven hepatocellular carcinoma shown on ultrasound. Ultimately, it was 8 months between the Primavist MR and the ultrasound scan, confidently diagnosing this occult lesion from MR scan. So what does this show? It shows us that grayscale ultrasound has excellent spatial and contrast resolution. It shows baseline nodules with great accuracy, and the arterial phase imaging ultrasound has greater sensitivity to detect vascularity. And what we learn, of course, is that if a surveillance ultrasound shows an actual nodule, as here, that this cannot be ignored and that these patients must have CEUS. So what do the previous cases that we have looked at have in common? Well, virtually all of them have been small size. And so if you listen to what is often said about CEUS, that it is not good at characterization of small masses, I would suggest to you that this is definitely a myth. So let's look further at these lesions, these small tumors in patients at risk for HCC. So here's a 59-year-old male with ethanol cirrhosis and a nodule on surveillance ultrasound. So as I've mentioned, the recommendation is for MR to be the first test, and this shows arterial phase hyperenhancement. So there's our T1 dark nodule hyperenhancing and shows sustained enhancement. So this was felt to be LR4. So it's got part of the features to make it LR5, but no washout. So therefore, it's suspicious for HCC, but not an LR5. So the patient then comes to us for CEUS. And here you can see on the top line is the nodule, well seen. And in the wash-in phase, this is a hyperenhancing nodule. So at this point, it's concordant with the MR scan. However, if you look at the bottom line, we see the grayscale image on the left. Then at 35 seconds, the hyperenhancement. But by late washout, 2.5 minutes, we see late washout. And by 5 minutes, this is quite marked. So this patient has got APHE and late and weak washout, the characteristics for LR5, the characteristics for classic HCC, and this patient can be biopsied or can be treated without biopsy. So pathology confirmed HCC. So the change from LR4 to LR5 in our experience occurs often. And we've shown in two efforts that we have at the University of Calgary that contrast enhanced ultrasound shows washout more often than MR in confirmed cases of HCC. And so one of these publications in abdominal radiology by my student who's just finishing her treatment, her training with us, and another very exciting publication, which we hope to release later this year on the results of surveillance ultrasound, which shows that CEUS is a more natural first choice than MR in the evaluation of these patients. So now let's look at another patient. This is a 74-year-old male who has no risk factor for HCC. So he presents to our emergency department with abdominal discomfort, and he has an ultrasound. And so a large mass is incidentally detected. So there's his grayscale ultrasound with the arrow pointing to a large mass exophytic to the edge of the right lobe of his liver. So when we do CEUS, we can see that he's got very dysmorphic vessels within this mass. And definitely this is a heterogeneous hyperenhancing mass. And there you see our arterial phase enhancement. The mass fills from the periphery to the center, but these are dysmorphic vessels. That mass has APHE. So there's a image taken at the peak of the arterial phase enhancement, showing the fairly homogeneous arterial phase hyperenhancement. And then we watch it intermittently. And you can see at 90 seconds, we're starting to get very weak washout. And at 4 minutes, this is more confirmed, but still weak washout, retaining multiple bubbles within the tumor. So what do we think of this patient? So this is the non-risk patient. The liver is not cirrhotic and the patient has no known risk. But what do we see? We see arterial phase hyperenhancement and we see delayed weak washout. So what do we think? In any patient at any liver, we think hepatocellular carcinoma, and this is a confirmed hepatocellular carcinoma in a non-risk patient, but showing the identical features that we expect on CEUS for this diagnosis. So now let's look at two further similar patients, who we'll call again patients 1 and 2, a 61-year-old female and a 64-year-old male. And both of these patients have known confirmed cirrhosis, and each of them has a suspicious focus of APHE on MR scan. So let's look at these two very different patients. So patient number 1, you can see, looking at that peak arterial phase image, that there are foci of APHE everywhere. They're just all over that liver. So there are foci of APHE throughout that liver. And when we look at patient number 2 by comparison, this patient has a solitary focus of APHE. So in both cases, the patients had diffusion weighted imaging. They also had baseline T1 and T2 imaging, and there were no other observations. Additionally, on the contrast scans, when we look at the portal venous phase, there's no evidence of washout. And here, this is a small cyst. So how do we interpret this patient number 1 who has all of these multiple foci of APHE with no other abnormality? So they would be read anywhere as suspicious for arterial portal shunts. And so this is undoubtedly happens in many centers for many patients every day. So what about patient number 2, a more challenging case because it has no washout either. And it also has no abnormality on diffusion imaging, on T1 imaging or T2 imaging. So what does that solitary focus of APHE represent? Is this an arterial portal shunt, or could it be an HCC that doesn't have washout? And we don't know, of course, from this MR scan. So now let's look at what ultrasound contributes. Well, when we look at patient number 1, the patient who had all the multiple lesions in the liver appears homogeneous with no evidence of any nodules. Whereas when we look at patient number 2, corresponding precisely with the nodule on the MR scan, we show a hypoechoic nodule. So now let's go on to their CEUS results. So patient number 1 who has nodules everywhere, we inject contrast and then we do multiple sweeps as here, where the patient takes a big breath in, suspends their respiration, and then we sweep through the liver. Here we're going through the right lobe, but we would do another sweep for the left lobe and perhaps 2 or 3 sweeps to uncover the entire liver, and we show no evidence of any nodularity, we show no APHE, and we show no washout. Whereas when we come to the patient with the solitary nodule, we can see in the arterial phase that this is a nodule-based scan and that the nodule has got APHE. So this is very suspicious. And so when we look at the portal venous phase for patient number 1, we continue to show homogeneous enhancement, no APHE, no washout. So these are inconsequential arterial portal shunts, and this is supported by the appearance of no abnormality on CEUS. Patient number 2 has a nodule with APHE, and on later images, here we can see the late and the weak washout. This is again a classic HCC or LR5. So what do we see here? Well, we know that APHE on CEUS is virtually always nodule-based. Therefore, it has more specificity than APHE that is observed on CT or MR scan, which may frequently represent shunting with no other associated observations. So the demonstration of APHE on MRI or CT is an excellent indication for CEUS in the management of the small nodules that we see in those at risk for hepatocellular carcinoma. So now let's go on to talk about the contrast agents that we use to do these imaging tests. So for contrast-enhanced ultrasound, we use a purely intravascular contrast agent, whereas we're very aware that MRI and CT contrast agents have got a recognized interstitial phase where the contrast agent leaves the blood pool and goes into the interstitium, especially of tumors. And so therefore the advantage is clearly in favor of the intravascular contrast agents, which we have for CEUS. So let's look at an example where this was of importance. This is a 67-year-old female with HCV cirrhosis, a lesion found on surveillance ultrasound. So when we look first at CT scan, which she had, it's not very remarkable in the arterial phase, maybe a little heterogeneity in the corresponding area of the liver. But in the portal venous phase, the amount of enhancement has increased. And so this CT scan was questioned the possibility of an atypical hemangioma, and the patient at that point was sent for MR scan. So here we can see the arterial, portal venous, and delayed images, and they're very similar. There's rim kind of enhancement with some central enhancement, and there's no evidence of washout, and it was uncertain as to what this represented as well. And so what happens here, MRI was reported as indeterminate. And so the next study that happened was a CEUS. So here we can see the mass in the liver. And in the arterial phase, we can see immediately that we have rim arterial phase hyperenhancement. And then in the portal venous phase, we can see that by 50 seconds, so less than 1 minute, we have washout. So what do we know about this? Well, we have RIM APHE, we have rapid washout at less than 1 minute, and we have marked washout. And so as we regard washout as such a suspicious feature for malignancy, we recommend a biopsy, thinking this is a non-hepatocellular carcinoma, and biopsy shows that this is a cholangiocarcinoma. So in this case, you can see that the MRI and the ultrasound in the portal venous and late phase are discordant, in that the CEUS exam shows rapid marked washout, whereas CT and MR scan show instead increased enhancement. And this is related to the fact that the CEUS with a purely intravascular contrast agent shows washout with malignancy as we want it to do, whereas the MRI scan causes pseudo-enhancement related to interstitial contrast agent, which occurs due to the interstitial phase that we recognize for those contrast agents. So another similar case, an elderly male, mass on grayscale ultrasound of very large size. This patient has an MR scan, and you can see in the early arterial phase that the lesion is very dark compared to the rest of the liver. And then in the late portal venous phase, we have increased signal intensity. And so the impression that was read at the time that this MR scan was performed, not in our institution, but elsewhere, was that this was perhaps a hemangioma. Now, after presentation at HPB or HPB rounds and a second opinion, it was felt that this could be cholangiocarcinoma. So when the patient comes for ultrasound, we can see the mass, easily a big mass, hyperenhancing in the early phase. And then as we continue to watch, you can see right before our eyes, it's washing out. So RIM hyperenhancement, rapid washout before 1 minute. And at 2 minutes, when we sweep this mass on the bottom line, you can see the marked washout. So washout, the hallmark of malignancy, is beautifully shown on purely intravascular contrast agents for ultrasound, whereas MR scan shows pseudo-enhancement, increasing the options for interpretation for the MR radiologists. Another similar patient shows an arterial phase hyperenhancing, and in the late phase, there's no washout, or could this be a necrotic tumor? And so this was felt to be uncertain. Patient comes for ultrasound, we show this very echogenic mass, and when we do our arterial phase injection of contrast, we can see immediately that this has RIM hyperenhancement, and then when we look further, we can see that at 1 minute, the RIM is completely gone, and by 5 minutes, the washout is marked. So this is LRM, or non-hepatocellular malignancy, on CEUS, and discordant from the result on MR scan, where we have RIM enhancement with sustained RIM enhancement, which is pseudo-enhancement related to interstitial contrast. So what we have learned in our hands is that we should biopsy all cases with portal venous phase discordance of this type. Additionally, we biopsy all LRM and all cases in non-cirrhotic livers that are suspected to be non-hepatocellular malignancy. And so let's end with just a short word about other malignant tumors. So we know that on CEUS, the timing of washout is discriminatory, and we know that metastases wash out very fast, often within the time frame of the arterial phase, and they tend to wash out completely. So let's look at a clinical place where it makes a big difference. So this was a 52-year-old man who had a history of pancreatic cancer, and he had this CT scan showing this low attenuation mass in his liver. There were other smaller low attenuation areas that were felt to probably be cysts, and there was a question about this one. Consequently, the patient had a PET scan, and the PET scan was recorded as negative. And when the patient came to us, the patient said to me, "Dr. Wilson, I'm not worried because they told me the PET scan is very, very reliable, but the PET scan is not reliable for everything. So when we do the ultrasound, we can see that yes, there is a cyst there corresponding to the CT abnormality, but it's surrounded by a hypoechoic soft tissue solid rim. And when we do contrast enhanced ultrasound, we can see that the cystic component of the mass continues to be black, but that we show we're moving around a bit here to optimize the visualization. We can see that the rim of this mass is enhancing. So at 30 seconds, we have an image showing heterogeneous enhancement of the rim. And by 1 minute, it's definitely washed out. And by 4 minutes, it's marked washout. So this suggests to us a complex cystic mass with arterial phase enhancement with rapid marked washout. We're thinking non-hepatocellular malignancy. We biopsy all of these, and this is a confirmed cystic pancreatic metastasis. And it shows, similar to Dr. Barr's presentation, the tremendous value of ultrasound with CEUS for all cystic neoplasms. And here we'll end with this shocking example. So this is a case I saw years ago in Toronto when I was there. This is a patient with a liver that we called normal when this patient presented to us. However, shortly after, we did a CEUS, and you can see in the arterial phase that this very normal looking liver on grayscale is riddled with small hypoechoic masses. And when we get to the portal phase and sweep through this liver, so this is a liver that has literally got hundreds and hundreds of tiny metastases, which are occult on the grayscale scan. And I'll end with this very last case. This is a 60-year-old male who has fatigue, and this is his baseline grayscale ultrasound and his unenhanced CT. And so the baseline ultrasound is quite abnormal looking, although I would be at a loss to say what it looks like it represents. And the CT scan, I would suggest, is less abnormal. And so nobody would interpret the CT scan without contrast agent. And I would suggest to you that nobody should interpret the ultrasound scan without contrast either. So when we look at the contrast images, these images, I will point out to you, are now more than 20 years old. They were taken in 2001. So when we inject the contrast, you can see how very well both studies show the metastatic disease in the liver. And so I suggest that both CT and ultrasound require contrast agents for the detection and the characterization of liver masses. So what did we look at? Well, we feel that in the liver, it is the unique features of CEUS that make it invaluable. It has especially high resolution, dynamic, real-time scanning, and purely intravascular bubbles. And here I'm not even mentioning the thin slice thickness and the microbubble only imaging. But what comes from this? Well, when we consider the liver, CEUS is a major problem solver, and it resolves indeterminate CT and MR scan. Thank you for your attention.
Thank you so much, Dr. Wilson. It is now my pleasure to introduce our third speaker, Casa Dargay, MD, PhD, DTM and P, FA, IUM, FSAR, Professor of Radiology and Surgery, Pereal School of Medicine, University of Pennsylvania, Radiologist in Chief, and the William L. Vann Endowed Chair, Department of Radiology, Children's Hospital of Philadelphia. Dr. Dargay.
Good afternoon, everyone. So in the next half hour, I would like to cover some of the pediatric applications of contrast-enhanced ultrasound. I just want to say thank you again for the organizers for inviting me to join this ICAS session, and also to put out the pediatric utility of contrast-enhanced ultrasound. I don't have direct personal engagements, but I, as the chief of the department, and also we have a Center for Pediatric Contrast Ultrasound, we do have a lot of grants related to contrast-enhanced ultrasound from all these institutions funding institutions, societies, and companies. So these are all listed here. I want to focus on pediatric contrast ultrasound and give you some overview with some tips and updates pertaining to clinical activities and some research advances. So let us start with the clinical activities. As you know, there are few contrast agents in the US, and the first one that had been around earlier are Definity and Optizone. And as you can see from this presentation, they are only approved for adults and not in children. In 2016, the FDA approved the ultrasound contrast agent Lumason for both for adult and pediatric use, including for cardiac, liver, and urinary tract, especially pertaining to vesicourethral reflux detection. So I want to go over some of the advantages for pediatrics. There is no doubt now, after almost over 25 years of use of contrast ultrasound, that means about 20 years before the introduction in the US, contrast ultrasound was being used already in Europe in children. And there are many, many studies that have demonstrated the high sensitivity of this modality, increasing also the diagnostic conspicuity in many instances. So this is undoubtedly for many applications true and is a really important consideration when you think of using contrast ultrasound. In addition to that, it facilitates a lot of workflow issues. Why? We can do point of care bedside ultrasound. We can do easily intraoperative ultrasounds. We can do just-in-time examination, meaning if we see a lesion, we can decide right there to add contrast and definitely make a proper diagnosis of the lesion. And there is a lot of possibility of eliminating sedation or anesthesia because we are able to replace CT or MRI. As you know, patient and family experience that is monitored closely in many of our institutions is something that is affected by the use of contrast ultrasound. Why? It increases the comfort of examination because you're doing ultrasound, which is a small machine near the patient. It allows the family to be next to the child. You can scan the child in different positions. If we're doing voiding, you can have the child void in physiological position, put them on a potty or stand up and you void in a urinal. The cost, an important aspect, is also less than CT or MRI in many instances. And we should also not neglect the safety. It has high safety profile, the ultrasound contrast agent. It's non-nephrotoxic. And by using that, we eliminate radiation or reduce the use of radiation. That's a safety consideration, an important one in children. And of course, technically, we have higher resolution with the ultrasound and real-time dynamic examination. It can be beneficial in many instances. So with all these advantages, and lastly, in low-resource countries or places, ultrasound with ultrasound contrast may be easily used than trying to do fluoroscopy, CT, or MRI. So with all these advantages, what are the challenges with contrast ultrasound in children? One of the main things is just a culture change. Culture change is also one that is not easy. Non-contrast modality to a contrast one, that's a new culture. The need for IV line or catheter placement in a modality where you never had this before, that's a culture change. And then, especially in our US setting, where the frontline colleagues that scan the patient are the sonographers, these exams may entail more involvement of the pediatric radiologists. And especially in times of increased volume, less staffing, that may be a challenge for people. But all these aspects are something that one can work on and change in one's department to enable to have a successful service with contrast ultrasound. Some may struggle because we do the application not only for the 3 indications that FDA has approved, but for others also. So the FDA has approved it for liver, but we inject and we scan the spleen or the pancreas or the kidneys. It's the same route. It's the same potential of safety effect. However, those are not strictly labeled as the FDA-approved indication. This may be an issue for some people, but I can only assure you that off-label use is also something that is approved by the FDA, and especially in such cases where the safety profile does not change, but only the position of your transducer, it should not be a major issue. And lastly, the issue of cost and profit. People may be worried, oh, we should have done MRI with EOVIS. Now we did only ultrasound with contrast and avoided the MRI. So that's a loss of income in terms of losing MRI. True. I mean, that may be an issue in an adult setting where you have a lot of studies that you can take over with ultrasound contrast studies, because you also have the pathologies like focal liver lesions, like Dr. Wilson just reviewed for us. In pediatrics, those are rare, and the chances of reducing the MRs to such an extent to affect profit is really, really negligible. Why? Number one, the MRs involve many more ancillary stuff like sedation, anesthesia, nursing, which is very costly and sometimes also not well reimbursed. Secondly, this affects the safety and wellness of the child. So that's something we have to remember. Thirdly, because we have contrast ultrasound in children, we are doing now more indications for this specific study. And so that also will support the profit margin for practices and make it less of an issue. For those of you who are really thinking about or worrying about off-label or on-label stuff, this is, I think, the best publication that clearly describes what an off-label use is and that it can be used without much worry. So for those really interested in digging more into this, I highly recommend this publication. And realizing that the route of administration is the same for regards adverse event, but the position of the ultrasound transducer may be different. So this is something also to remember. So let me start with intravenous applications in children. And no doubt you have seen now many examples of liver studies in adults. These are less common in children, but even the few that we have, we're able to evaluate, like in this case, this lesion that enhances and then washes out early, and it turns out to be early washout, malignant until proven otherwise. This was a hepatoblastoma. So this is one on-label indication. However, we have other important indications, and I want to thank my colleagues who are pushing these indications in our department, both in terms of clinical application and research. So one is bowel perfusion, and this is in inflammatory bowel disease and necrotizing enterocolitis, which is common in newborns. And this is for the detection of the perfusion and also for the inflammatory activity monitoring. The advantage is that we can do bedside evaluation, especially for patients with necrotizing and enterocolitis who are in the ICU, newborns. And we can also do frequent monitoring. And we're really working on this. And we have currently from the FDA an investigational new drug IND approval for evaluating for necrotizing enterocolitis. So this is an example of an 11-year-old female who had for 2 weeks bloody stool and abdominal pain. You see on the color Doppler, there is some flow in the wall. The wall appears thickened, but when you look at the contrast enhancement, look at this rectum in transverse, you see there is increased enhancement that really persists. You see it, it's like a ring. And when you have quick wash-in, transmural enhancement, and persistent enhancement and slow washout, that is a sign of active inflammation. So you have already some information just by the injection and evaluating subjectively the bowel wall. In addition to that, it is possible to do a dynamic evaluation and do regions of interest and evaluate the peak enhancement in area under the curve, which would give you more information with regard to the status of the activity of the inflammatory bowel disease. Another application that's coming into practice is hip joint. And this is very pediatric because usually children can have hip dysplasia. They go to the orthopedic surgeon and they adjust the femoral head to be sitting appropriately, and then they put a spica cast. This is done in the OR for hip reduction. And then what happens in current state is that they send the patient to MRI after the OR. And usually you don't have the MRI in the OR, so they have to go to another MR site to be evaluated post-op while under the same anesthesia to see whether the femoral head is perfused or not, and that the placement of the spica cast is not cutting off the perfusion. So, but replacing the MRI with ultrasound contrast intraoperatively avoids putting the patient in an MRI moving. And if there is no perfusion, then the patient has to go back to the OR, then there is another spica cast, and then there may be another repeat MRI. So this avoids, ultrasound avoids that. So the way this is scanned is you can see it, and after spica cast placement, you can see the scan. You're looking at the epiphysis, the cartilaginous part, with and without the cast, and you adapt the plane to the window. So then when you inject, this is the cartilage, this is the bony nucleus. You see in the cartilage, you see some of the blood vessels coming in, being visible after the injection. And this is nicely described. Here you see the ossific densities and then the epiphyseal vessels that are now coming to be visible here. Yeah. And that shows pre-reduction. And this is also here a nice depiction of the epiphyseal vessels. So that means there is perfusion, and you can avoid doing MRI. Let's go to intracavitary application. And in that is, the intravesical one is the dominant one. It is called contrast enhanced voiding urosonography. What do? We inject contrast in the bladder and try to see whether there is reflux. We not only see reflux very well here, the calyces filled with contrast, but look at this. This is intrarenal reflux. The microbubbles are surging up into the cortical region here. And you can see it so beautifully on real time when this is happening. So this method has really high sensitivity and conspicuity, not only for the detection of vesicourethral reflux, but also for the visualization of intrarenal reflux. Here is a panoramic view. This is one image. This is not photoshopped. This is a small baby with reflux on both sides. These are coronal images from the flank. The right renal pelvis massively dilated, reflux here, even intrarenal reflux is noted tortuous ureter, bladder. Then the left ureter, dilated, tortuous, dilated renal pelvis, some intrarenal reflux. All this in one image, and this is certainly an exquisite view of the pathology of a bilateral high-grade reflux in this patient. Here you see it, the scan on the coronal plane, again, in real time. You see the bladder, the ureter, how it connects to the renal pelvis. This is to show the conspicuity of the depiction of the reflux. In addition to that, we image the urethra like we do with voiding cystourethropy. You can do it suprapubic or transperineal, and you can see all kinds of urethral pathologies that you're used to seeing on VCUG: posterior urethral valve, anterior urethral valve, a prolapsed ureter, an ectopic ureter, a urethral stricture, or ruptured anterior urethral diverticulum, or prostatic utricle diverticulum. All these can be depicted with the contrast-enhanced voiding urosonography examination. We also do contrast-enhanced genital sonography, which we used to do only with fluoroscopy. And this is an example in a female 5-month-old with congenital adrenal hyperplasia and disorder of sexual differentiation. So when we fill the bladder and the patient starts voiding, what do you see? You see contrast flowing backwards in this structure, yeah, which is connected here to the urethra. And this is the vagina where it is connecting. You see it here nicely when we put up in comparative planes the images. Here the vagina, here the fluoroscopic image, the vagina, here the urethra. So you have a urogenital sinus here, and that's also here depicted. So this is a contrast-enhanced genital sonography. Then another major applications that is now in our department and carried out by all our pediatric interventional radiologists is the use of contrast ultrasound with the use of contrast agent for interventional procedures involving biopsy guidance, cavity evaluation, enteric tube check, perfusion pre and post intervention. Let me give you one example in a male 2-month-old who had a left thigh mass and biopsy was required. So this is the gray scale, and normally you would just go in and take a biopsy. And unfortunately, that could result in many false negative or none or just necrotic tissue. However, when you give the contrast, it does show you that actually the only viable tissue is in the lower portion. So in this portion. So that means the interventional radiologist goes to biopsy this area and then get the appropriate tissue. So this is really an exquisite use of contrast enhanced ultrasound in a pediatric patient to make this diagnosis. And in this case, it was infantile myofibroma. The last application that we have introduced in children is the intralymphatic use. So we have all the lymphatic system, quite complicated, but we usually do MR lymphangiography to see the thoracic duct here opening and all the lymphatic channels. However, to guide us to inject the contrast for MR lymphangiography, this method is very helpful to identify the lymph nodes and inject in the right place and ensure that the needle is in the lymph node to inject the MR contrast agent for MR lymphangiography. The other application is to see the patency of the thoracic duct. Advantages include that you can do the procedure at the bedside, and also you have a better conspicuity of the contrast. So here the technique that my colleagues use, identify the inguinal lymph nodes under ultrasound and inject the contrast agent under ultrasound and ensure that they are well placed in the in the lymph node, that's one, or evaluating the thoracic duct with the ultrasound of the neck. Here, an example to show the patent thoracic duct. They inject the contrast, and soon you will see that you see this flow, no doubt the thoracic duct is patent. On the other hand, here they had injected. It was difficult to determine from the MR lymphangiography. And here with the contrast injection, you don't see that contrast flow that I showed you before. And this is an occluded thoracic duct. So very helpful in unequivocally demonstrating the patency or not. And lastly, let me go into a few applications of label and research. This is a male 7-year-old with bicycle accident, blunt abdominal trauma. You can see the trauma in the spleen without any doubt. And I can mention to you that this is important. So there are a number of comparative research going on at this moment at Boston's Children and at CHOP also, including for the evaluation of child abuse. I just want to emphasize how important this application is and that there are many attempts to be able to use it. Furthermore, we are looking into the potential use of evaluating in the fetus. Our surgeons are working on an artificial womb with a LAMP model. And here there are different possibilities to evaluate for congenital diaphragmatic hernia and evaluate the lung perfusion. And when this comes to patients, which we hope will happen in the next year, we will be able to do bedside monitoring and use lung perfusion as a biomarker. Here, the fetal lump, you see how the lungs are exquisitely demonstrated in the contrast enhanced ultrasound. This is the normal lung, and this is the CDH lung. You see the hernia here very well. And then you can again do a dynamic evaluation and generate a number of parameters that can be used to evaluate. Furthermore, there is a possibility to evaluate the brain for perfusion and also for intracranial pressure, which is a bedside and also non-invasive. So here you see the normal fetal lamp brain perfusion, and you can even detect the high resolution single micro bubbles perfusion in the brain here in the fetal model. We have the same thing and do it now in newborns to detect hypoxic ischemic injuries and monitoring treatment hypothermia. Main advantage being bedside monitoring, and we have an approved IND study. And this is the contrast enhancement of the brain, where you can do also dynamic enhancement. This image beautifully shows that the central nuclei are more perfused than the cortex. That's the normal finding. If that's not the case, like in this patient, where the enhancement of the cortex is equal or more than the central nuclei, you have issues with brain ischemia that can be confirmed on MRI. So the take-home point regarding pediatric contrast ultrasound is that it's really advancing since the FDA pediatric approval. We have intravenous, intracavitary, interventional, and intralymphatic applications, and many on and off label use of contrast ultrasound. There are many people in my department who are involved with the Center for Pediatric Contrast Ultrasound, all those listed here, with the leader being Susan Back. I want to thank them, all of them, for this. Thank you for your attention. And these twinkle and bubble are our models, phantoms, for evaluating contrast enhanced voiding urosonography. Thank you very much for your attention.
Thank you so much, Dr. Garde. We sure appreciate everyone's presentations. And now we're going to look to the Q&A window. So at the bottom of your screen, type in your questions for our faculty. And any questions that will be directed to Dr. Barr, he is unable to attend our live Q&A session. So we will have Dr. Dargay as well as Dr. Wilson for our live question and answer period here.
If no one is typing a question at this moment, I want to put in a question for our audience. If you're doing pediatric contrast ultrasound or contrast ultrasound in children in your institution, just say so. Put it in the chat, which institution I would like to see. Thank you. So we have one question. Do all contrast enhanced ultrasound procedures require a radiologist to be present? In my experience with pediatric, the people who we trained first are the sonographers. And if they are well trained, really, you may not need to be present, especially if you have a second sonographer that can help with the injection, because one sonographer alone may not be able to do injecting and scanning. So if there is another person, then it works out. So it's not really a must to have in every study. Yeah. For instance, like we have an old routine trauma study, they would do it and then we would look at the images, and if we have questions, we go in. So that's something that you want to be aware of. Stephanie, how do you see that?
Can you hear me? I can't see my controls anymore.
We hear you very well and see you very well.
Perfect. No, I'd love to say something about that. I think that your department and my department represent a desired endpoint. And so certainly in North America, there is no doubt that the sonographers become a critical component of a successful, well-run department. And so although I'm always present in my department and I involve myself at various points along the way of doing a complete examination, yes, my sonographers are very, very capable. They can do virtually everything themselves and extremely competently. And so you want to have a team. I know you've always emphasized that, Casa, that you have to have a team of people really involved to successfully do the CEUS.
Yeah. There is now a question, would this eliminate the need for biopsies in children? No, it's not eliminating the biopsies. Okay, so there are two things. If you have a definite diagnosis, let's say you have a lesion in the liver and definitely after contrast, you know it's an hemangioma or FNH, then you do save children having biopsies in uncertain cases, especially if you're not doing MRI or so for further evaluation. But also, as I showed, the interventional application is when you do biopsy, you have the option to inject and select the more viable area to take a sample from.
I'll make a comment there. I think that the question about whether you eliminate biopsies has got a different slant when you're considering the pediatric population. But in adults and in children, there is absolutely no doubt that doing contrast ultrasound does reduce the need for biopsy. And if you consider, for example, even in patients that have cancer, I mean, it's recognized by pathology departments and by the health system as at large that when you start biopsying things like every patient with a hepatocellular carcinoma, it became obvious that if we do good ultrasound and good imaging, we can eliminate those biopsies. And so that's a benefit for the patients and the healthcare system. And then, Casa, your point about optimizing the biopsy, there is absolutely no doubt that in difficult biopsies, ultrasound, first of all, helps to localize the lesion, and CEUS helps to localize the part of the mass that is most optimally biopsied. And so the role of CEUS for biopsy is really huge, I believe, and for assisting interventional procedures, and especially in assisting in ablative procedures, is excellent.
Thank you very much. Any further questions? Are there anything you would think of could be a hurdle to introducing a contrast ultrasound service? If there is, please address it so that we can talk about it and see what solutions there are. Any hurdles that you may have. Of course, staffing is an issue, could be an issue. Time is an issue. All those things are real issues, but any other technical. Are there limits to the amount of contrast used in ultrasound versus MRI, CT? So there are FDA guidelines. If you follow those specific guidelines, there are total amount of contrast that you are supposed to give at one time as a bolus plus as a total volume. So there is a certain FDA limits. That's if you do it on label and specifically according to the FDA. If you do it off label, that depends on how you use it. But what definitely is the case is that you use from a volume perspective, significantly smaller amounts, especially in children, when you think about 0.03 ml per kilogram. These are tiny amounts, sometimes so small you do have to inject a normal saline after administering the contrast, even to push it from the IV line.
I'll make a comment there about dosing. So certainly in adult patients, the questions, if we look at them from a slightly different perspective, so there's a lot of people who are suspicious that you can't look at an entire liver, for example, with contrast enhanced ultrasound. And certainly you can. So in other words, we don't find in adults that a limitation on the amount of contrast we can inject ever stops us from completing an exam. And you can do multiple injections on a single patient, and that can be repeated as often really as you want. And so I don't believe that the amount of contrast is a limitation, certainly in the adult population.